mainly used for sorry, for doubles and stuff like that, like numbers where.
So, I know there's somebody not muted.
So we normally, after the theatre session, we'd go straight to the planning MRI and plan on the MRI. But you mentioned in your slides that you would do a CT planning at 9:30 and then an MRI at 11. I was just wondering why that was the case.
Yeah, we only do one. We only do one MRI. We don't have a lot of MRI capacity here at Derby, and all of our planning for brachytherapy is currently commissioned on a CT scan. So we aren't commissioned to plan on MRI. We are commissioned to plan on CT. MRI is brilliant because it gives us much better visualization of the cervix, and especially like the organs at risk. They're so much easier to visualize, but most of it at the moment is just down to capacity.
Okay.
And yeah, MRI just isn't available to us.
Thanks very much. I think in the interest of time, we're going to have to move on. Any other questions we'll try and answer in the chat box. I'll hand you back to Susie to introduce Human.
Okay, great. Well, thanks very much for those fantastic presentations. And we're going to take a bit of a change in direction now and head back towards surgery. And we've got two expert speakers for you this afternoon. So first, I want to welcome a very dear guest and previous mentor of mine, Mr. Human Soleimani. So Mr. Soleimani has been a consultant gynaecologist at Churchill Hospital in Oxford since 2016, where he also completed his subspecialty training. His areas of surgical expertise include ultraradical surgery for advanced ovarian cancer and the management of patients with placenta accreta spectrum. Mr. Soleimani is a founding member and surgical lead for the OXPAT group and member also of the Oxford Sarcoma team. He is a well-published author, peer reviewer, and an honorary senior clinical lecturer in gynaecological oncology surgery for the University of Oxford. So thank you very much for being here.
Thank you very much. Just to confirm, you could see my slides, correct?
Not yet.
Not yet.
So I think I did share my...
Want to share again?
Let's share again. So... could you see it now?
Yes, we can see your desktop.
And the PowerPoint presentation as well?
Yes.
Yes, excellent. So thank you very much. Firstly, Susie and Sumi, many thanks for kind invitation. I would say just until now, my knowledge has quadrupled. Thanks for your fantastic speakers. You did say at the beginning that Susie is the best trainee or fellow you have had. We echo the same statement. We also concur with you, but we will remain to be envious of you kidnapping Susie from Oxford.
She's come to a better place. That's fine.
Well, I beg to differ, but I'm sure she has. I'm sure she has. But it's amazing to see Susie's progress. But thank you very much again for invitation. I'm the last speaker before the coffee break. It's always a bit of pressure on the speaker to be able to keep the audience awake. As a surgeon, I'll try to entertain everyone with some surgical photos. Hopefully, we will all enjoy this presentation. Now, I'm going to take you through fertility-sparing surgery in cervical cancer. I think it's a very well-chosen subject, given the number of patients now these days are requiring treatments as such. The objectives of my talk are going to be on the incidence of cervical cancer in reproductive age group. Then we will have a quick chat about the implementation spike we introduced in 2018. It led to a great deal of confusion at the beginning. I think we all do agree now we're settling now with this new classification. Then I will take you through the algorithm for patient management and the preoperative workup, what we do in Oxford, and also understanding the trachelectomy. I'm going to take the audience through the concept, history, and steps involved, because we do have colleagues on the call that are not gynaecological surgeons. Then we will talk about the complications of the surgery, oncological outcomes, and post-op monitoring and surveillance, which is very important, and also some key published trials. And I will have hopefully some take-home messages that we could have some interactions to see what would be the best forward. I will not cover the cervical cancer in pregnancy because neoplasia in pregnancy is a broad subject, but I will have some slides and I'm happy to take questions if audience had any questions. Now, if you look at the Cancer Research UK data, you will see when we look at the incidence in the reproductive age group of the cervical cancer, these are typically women who are under the age of 45, who for some reason they have delayed the conception later on in the third or fourth decade of their life, and they're going to embark on pregnancy, and then now have been diagnosed with, unfortunately, cervical cancer. And we have seen and witnessed trends in delayed pregnancy over the last few decades. Hence, fertility-sparing surgery has become a very important subject. Now, in 2018, FIGO decided to make some changes in the classification. One of them has applied to earliest stage cervical cancer, and we know that the width of the tumor is no longer counted when it comes to defining the earliest stage cervical cancer, and the lateral extent of the carcinoma is no longer considered in distinguishing between FIGO stage 1A and 1B. And if margins of loop are involved, patient is allocated to 1B1, and that has resulted on performing additional loops or excisions to be able to decide exactly what the stage the patient is before embarking on many major operation. The algorithm I have been following and I have contributed to develop in Oxford is designed to be able to triage this patient according to the histological type and the tumor size. So globally, the main recommendation is that we do offer fertility-sparing operation to women with the cervical cancer up to 2 centimeters. And these women should have very common histological type, squamous cell carcinoma, adenocarcinoma, villi glandular will also fall in this group, and adenosquamous, and we will not be offering fertility preservation for more biologically aggressive tumor. And we do request MRI for these women. It's very important to be able to radiologically stage these women with MRI contrast, and we do that for 1A2 and a stage 1B1 and 1B2, and also we will do that for a stage 1A1 if we have LVSI. So the management of a stage 1A1 is very straightforward. We offer this women conization or large loop excision of the cervix. And when we do that, we prefer a non-fragmented specimen with a 3 millimeter negative margin for cancer is highly recommended, as is consistent with NCCN, BGCS, and ESCO guideline. And for women who have LVSI, we also offer bilateral systematic pelvic lymph node dissection. And whenever it's doable, still is not a common practice, we will offer sentinel node as well. We have to wait for the Cervical 2 and 3 trials to conclude which direction we will be heading. For a stage 1A2, we offer conization or cold knife with bilateral pelvic lymph node dissection, or we could offer these women simple trachelectomy, and that would be followed by systematic pelvic lymph node dissection. For larger tumor, my preference is to do radical trachelectomy, and that would be either with pelvic lymph node dissection, and if the patient, for example, had some high-risk features, you might wish to organize a whole body PET-CT scan, or you need to have some means of assessing the para-aortic lymph node dissection. NCCN has left this optional, and that would be the discretion of the gynaecological surgeon who carries this. I can't get to next slide. Okay, now. So what is very important is the preoperative workup of this patient. Remember, trachelectomy sounds, or fertility preservation might sound very exciting for the operating surgeon, but on the receiving end, you have a patient and a family which you need to look after. And there is no way that you could look after them without having a holistic approach to the patient's care. So holistic approach to patient's care, especially this cohort of patients who are very anxious, is paramount. And the way how we do that, we start off by ascertaining a very full and thorough and comprehensive history, taking into consideration the patient wishes. If you follow me, this is what I call a circle of trust, and I'm going clockwise. And the next step is a comprehensive discussion of the pros and cons of the surgery, very honest and very transparent and very truthful about the outcome. And also make sure you're not missing any coexisting other pathologies. For example, your patient might have a PCOS and in fact has atypia or hyperplasia. You need to be very careful of that and not treating someone for cervical cancer and 6 months down the line, you find actually she has atypical hyperplasia. You've got to be very careful with patient selection. And also you need to focus on the management of the patient's expectations. How do we do that? Of course, counseling is very important. As I said previously today, that the role of a cancer nurse specialist is quite crucial because they are the one who will help and facilitate the journey for these patients and try to be there for them whenever they have questions, and also stop the gynaecological surgeons perhaps to do more or cause harm. And the next step is to make sure that we seek advice from the specialist fertility team. In Oxford, we have a dedicated reproductive consultant gynecologists who look after our patients who require fertility preservation. Doesn't have to be cervical cancer. I'm talking about all cancer. So those people are with us and they look after our patients. And also we send these patients to high-risk obstetricians who would wish to see them in preconceptual clinic to discuss the nitty-gritty of what could happen. And some of these patients, because of the multiple loops they have had, they might choose to send them for elective cerclage. Then, of course, the patient will be able to make an informed decision, and the treatment then will be undertaken in a supportive of the patients, and it will remain to be the patient-centered treatment. And this is what is so important to be able to achieve the results we want. Now, what is trachelectomy? Tracheles is a Greek word, means neck, means cervix. Trachelectomy is when we remove the cervix and the neighboring tissue, also is known as cervicectomy. So what we do is, I've put these slides for colleagues who don't operate on these patients, basically in a nutshell, that we remove the cervix and the neighboring tissue, and the neighboring tissues are paracolpium, parametrium, and the upper vagina. And then what we will then do, anastomose the uterine body back to the vagina. This is a new cervix which is now formed, and this is where the anastomosis has happened. You can see on the right-hand side, the cervix, upper vagina, parametrium, and paracolpium is mobilized, and this is divided at the level of isthmus, and then the surgeon will apply what we call a cerclage to prevent these women from going to labor early. When we talk about cervical cancer, it's very difficult to talk about cervical cancer and not talk about the history. I have a very special passion about knowing where things started off, because that has always helped me to find new things to do. But when we talk about trachelectomy, we need to know that the first vaginal hysterectomy was done by Professor Schoutau. In fact, he was the one who did the first radical vaginal trachelectomy for the cervical cancer. And it was Ernest Wertheim, student of Schoutau, which then helped to contribute the abdominal radical Wertheim hysterectomy, the operation we keep explaining to the patient that you're going to have a Wertheim. And it was not until 1994 when Daniel Darjan carried out the first radical vaginal trachelectomy based on the hard work Schoutau did over the years. Now, the first abdominal radical trachelectomy was published by Smith et al. In 1997. And the robotic assisted abdominal laparoscopic radical trachelectomy, which was the first series of robotic surgery, was published in 2008 by Persson and colleague in Gynecology Oncology. And it was Kim et al. In later on in 2010, they published the first fertility-sparing laparoscopic radical trachelectomy for young women with earliest stage cervical cancer. If I move to the next slide, yes. Now, there was a very comprehensive review published by Jason Wright about the trends in use and survival associated with fertility sparing trachelectomy for young women with earliest stage cervical cancer. This was a very interesting and also very helpful review, because you look at the National Cancer Database, the time frame was between 2004 to 2014, 15,000 women were recruited in this study. And what they noted was 97% of women had opted to have definitive radical vertime hysterectomy, but in fact 3% had trachelectomy. But when they look at the trachelectomy trends, they realize that the trachelectomy rates more than doubled in 10 years. And the greatest rise was seen in women under the age of 30, and 1/3, in fact, had tumor more than 2 centimeters with a similar mortality. Another very important review when we talk about trachelectomy is to look at what Enrica Bettivegna and also Professor Philip Morris published in Lancet Oncology, was to look at and comparing 6 different fertility-sparing procedures for over 3,000 women. And there were many findings of this study, and that's 6 different treatment modalities, in fact, included the neoadjuvant chemotherapy, followed by surgery as well. And there were key findings from this study, and one of them was that if the tumor size is more than 2 centimeters, the risk of recurrence in the vaginal trachelectomy group was 17% as in comparison with 4%. Hence, we all globally have agreed on the fact that we should not be offering trachelectomy when the tumor is more than 2 centimeters. Now, we heard from Sid Dobbs earlier on today, and also we have been discussing about the LAC trial. The world, I always say the world, we were all in peace and having a good time doing a laparoscopic vertime hysterectomy for cervical cancer, because we knew that this was one of the best operation we were doing in terms of the anatomical dissection and also trying to be very precise. But then we were hit by this study published in 2018 by Pedro Ramirez and Andreas Obermeier, Pedro from MD Anderson and Andreas from Australia. It's a LAC trial which then showed that if you are treated by means of minimal access surgery, either robotically or laparoscopically with the cervical cancer, you are 6 times more likely to die. Hence, immediately the day after, the tsunami came and we all stopped doing laparoscopic or minimal access surgery for cervical cancer, and we had to go back to do this via open routes. At the same time, Gloria Salvo and Pedro Ramirez were collecting data for a study called IRTA study, International Radical Trachelectomy Assessment, a retrospective registry published in 2019 for 535 patients to understand whether the laparoscopy or robotic surgery is safe when the tumor is less than 2 centimeters, and whether we will be able to offer trachelectomy for women which are going through laparoscopy as opposed to have laparotomy. One of the key findings, and I have had this communication with Pedro about this paper as well, that even though the outcome appeared to be similar, but one of the things which they inferred from the outcome was a study was hindered by low numbers to determine if there is in fact a difference given the low numbers for recurrence in this patient. So even from the IRTA study, we have not yet managed to agree that we should be doing trachelectomies by means of laparoscopy. Hence, we will be again cautious when it comes to the mode of or treatment modality we choose. Now, what are the steps of nerve-sparing radical abdominal trachelectomy? And I've chosen these slides because I thought it would be useful for our audience who don't come to theater to understand what this operation would entail. And in fact, it's not an easy operation to do, and it's much easier to do this operation when you do the definitive treatment like abdominal trachelectomy, abdominal hysterectomy rather than trachelectomy. And we were getting the hang of laparoscopic total trachelectomy before the LAC trial came, so we had to switch to now abdominal trachelectomy. How do we do that? The operation starts off by midline laparotomy and pelvic sidewall dissection. We open all the avascular spaces in the pelvis, which are normally around 8, and then we do a systematic pelvic lymph node dissection, and I might choose to send some of these nodes for frozen section if the patient has high-risk features, for example, tumors getting closer to 2 centimeters, or you have LVSI or poorly differentiated. Now, if you just look at the anatomy we're talking about, this is a right pelvic side wall. This is a psoas muscle, genitofemoral nerve, external iliac vein, external iliac artery, the ureter, and these are the gonadal vessels, and this is a round ligament. So because we are going to preserve the fertility, we try to restore the anatomy as much as possible. As you could see, the round ligament is not divided, and the gonadal vessel is well preserved. Then, of course, we continue with the systematic lymph node dissection. This is an obturator fossa. Obturator nerve is fully exposed. This is very important nerve, as Susie said this morning. The nodal disease in this area is quite frequent, and it's very important to explore this area in its entirety and complete on the photo on the right-hand side, a systematic lymph node dissection before you continue with the rest of the operation. Now, the next step would be anterior and posterior colpotomy and measurement of the vaginal cuff from the central tumor bed and identification of at least a 2 centimeter clear margin. Again, you could see in this picture the tube and ovary are very preserved and perfused. The round ligaments are slung away, and we identify the vaginal cuff, measure that intraoperatively, make sure that we're not missing anything. And if we need to send more margins or frozen section, we would do that, because we don't want to come back or perhaps subject the patient to chemoradiotherapy, which could happen, but we try to maximize this intraoperatively. Then would be the complete detachment of cervix, vaginal cuff, paracolpium, and parametrium from the distal vagina. You could see we are now mobilizing, after the parametrium has been fully developed, we are mobilizing the cervix. I do my best to preserve the ascending branch of the uterine artery. I always sacrifice the descending branch. When we started doing this operation by laparotomy colleagues who were very keen to do laparoscopic radical trachelectomy, they always say that it's very difficult not to sacrifice the uterine artery when you do it with laparotomy or via laparotomy. I do agree with them. It's not easy, but if you look carefully, you might be able to do that. Again, it's not a big deal. So we know the trend has changed. Now you could sacrifice the uterine artery and nothing will happen to the uterus in order to get you a parametrium. Now, this is an operation we offer to women who have larger tumor, just under 2 centimeter, on the cusp of being 2 centimeter. And when the paracolpium and parametrium is fully developed, as you can see, the surgeon using the monopolar and divide that from the isthmus. And the next step is insertion of the Hegar dilator into the uterine cavity through the cervical os and perform the cerclage. So the way how we do that, as you can see, we have slung all the key structures. We put the Hegar dilator, and at this stage we put the cerclage, and we will tie that round the Hegar to be able to make sure this woman will not have preterm labor, or at least minimize the likelihood of that happening. Then when the stitch has applied, and I use Oprolin for this, I will leave the Foley catheter inside the uterine cavity, and I keep these patients in for 3 days, because that will create a new channel and hopefully will reduce the likelihood of hematometra or cervical stenosis. And the next step is basically the anastomosis. So we anastomose the uterine body back to the vagina anteriorly and posteriorly, and I use number 1 Vicryl for that. Now, what do we need to tell patients before doing this operation? I have these fingers on, and I said to my fellows as well to keep these numbers on the tip of their fingers, because ultimately these are the key numbers that you could look at. There are many papers published in this subject, but basically, in conclusion, we tell these patients while we see them with our CNSs is that the 5-year survival is around 95%. The recurrence is around 4 to 5%. And if this patient had relapse, 90% of these relapses are local and 10% are distant. And 10% of these women after the operation would require to have adjuvant treatment. Again, that would down to your patient selection and your preoperative workup and imaging. Hopefully you reduce that and make sure your patients will not fall into that intermediate or high risk category known as set list criteria. So you've got to be cautious with the patient selection. What about the complications short and long term? There are gynecological and obstetric complications when we do this operation. There is no operation without complication, but it's very important to be able to know how you would minimize them. From the gynecological aspect, this patient will have some psychological impact and anxiety. You need to make sure that if they require psychosexual counseling or referral to relevant services, that have all been in place. A lot of these patients will have abnormal cervical smear, so we need to know how we're going to deal with those. They do get a smear in different settings, but you have to make sure they are followed up in dedicated clinic by the operating surgeon. Dysmenorrhea is also quite common. Irregular bleeding, aperuria or dyspareunia is also common. Professor Keller presented not long ago the data from Germany, and he just say that a lot of these patients actually will not continue to be sexually active, something that we are uncomfortable to ask, but we've got to ask our patients after this operation, whether 6 months or 12 months down the line, are they sexually active or not. Cervical revision every now and then is required, is rare. I've done a few of those for patients who the other half would feel the cervical, so you have to be mindful of those, and that should not be an off-putting stumbling block for this patient to be sexually active. There's stenosis as well, and the lymphoedema. So we have to wait for the results of Cervical 3 as well, and Centix is ongoing to see whether we will be able to fully implement the sentinel node biopsy in the cervical cancer. Hopefully in years to come, we will see less and less lymphoedema. And also a quarter or half of the patient need assisted reproduction. We know they might require IVF, and you need to have a low threshold to refer them to colleagues who are able to do that. In terms of obstetric, recurrent miscarriages in these patients are higher, premature rupture membrane, preterm labor as well, increased perinatal morbidity and mortality, live birth is important, and also the NICU admission, NICU admission due prematurity, and if obviously these babies are born early, there will be a neurodevelopmental delay in future. And one thing which should be written everywhere in the patients, know the need for elective cesarean section. So if this patient comes in the middle of the night, the team on the ground should know this lady is not for vaginal birth. And these are the very important, I would say, medical legal documentation for a gynecologist to make sure these informations have been passed on to the patient and the family before they proceed with this operation, because this is a fertility preservation surgery. Now, we talked about how we're going to follow these patients up. So we know 59% of these patients had at least one abnormal pap smear following the study published by Elena Brown and also again Pedro Ramirez, but they identified that the pap test or smear after radical trachelectomy do not seem to greatly impact the management. But the question is how we're going to monitor this patient. So the post-op monitoring of this patient requires all hospitals to have a SOP, and this is a SOP I've written for Oxford. So the way how we do this, our patients would be seen in a dedicated colposcopy clinic by gynaecological surgeons, ideally the one who has carried out the operation. We will do a HPV testing, and the smear, whether you would like to do or not, that would be the discretion again of the person who has done the operation. But the colposcopy assessment of the vulva, vagina, and the neocervix is the must. FIGO suggests this patient needs to have 3 to 4 monthly follow-up in the first 2 to 3 years, then 6 monthly until 5 years, then annually for life. ESCO is a bit easier on this, so they say 3 to 4 monthly for 2 years, then 6 to 12 monthly for 5 years, then return to population-based screening. However, duration of follow-up can be tailored depending on the risk of recurrence or persistence of treatment-related complication. What about MRI or imaging? FIGO has said no routine imaging. What does it mean, no routine? So I think that for patients who have had large tumor, if somebody had a 2 centimeter or 90 millimeter tumor, has undergone radical abdominal trachelectomy, you need to have some means of monitoring. And for this patient, I do 6 monthly MRI for 2 years, then annually for up to 5 years, then I will follow them up to 10 years. But hopefully some of these our ladies will get pregnant and they will never get to have so many MRIs, but you have to have means of monitoring or close observation. What about the role of neoadjuvant chemotherapy prior to fertility-sparing surgery? We know a number of studies has looked at neoadjuvant chemotherapy in an attempt to reduce tumor size and allow for fertility-sparing surgery when otherwise it might not be possible. Studies have included a variety of different histological types and treatment modalities. PGCS recommendations are women who would not normally qualify for fertility-sparing surgery may be considered for neoadjuvant chemotherapy to reduce the size of the tumor. But they also state that if you want to use neoadjuvant chemotherapy pathway or protocol, you need to make sure these patients are audited or within a registered service evaluation project or in a clinical study. From my experience, the number of women coming with 2 or 3 or 4 centimeter tumor asking for fertility preservations are not many. Hence, you need to make sure they are part of the study or research. Now, obviously, we are all very eager to find out about the outcome of Contessa's study. Contessa is a study that has been led by Professor Frederic Amon. As we all know, he's one of the world experts in neoplasia and pregnancy. Basically, the objective of this trial is to evaluate the feasibility of preserving fertility in perimenopausal women with cervical lesions measuring 2 to 4 centimeters. And these are the patients who wish to preserve fertility, who will receive 3 cycles of platinum and Taxol, and patients with complete partial response will undergo fertility-sparing surgery, and then this will be followed up for 3 years. And further, we have to wait because they need 90 patients, and there have envisaged that this data will be available in 2025. So we will wait for that. Now, can we go less radical or not? Now, this is a very, I would say, it's a hot potato. I think everybody is talking about doing less, and maybe doing less is more. But if you, I'm sure everybody remember the paper published in 2011 by Kathleen Schmeller and again Pedro, look at the likelihood of having parametrial metastases or involvement when the tumor or otherwise small and you do not have high-risk features. For example, deep stromal invasion less than 10 millimeter and no LBSI and a smaller tumor. So they found only less than 1% of patients with earlier stage cervical cancer with favorable pathological characteristics have parametrial involvement. And that has led to a lot of papers and works and publications. One of them is already published. CONSERVE study is a single-arm prospective trial of conservative surgery for low-risk earlier stage cervical cancer by Kathleen Schmeller and Pedro. And the SHAPE trial, the data still is not out. The PR of that study is Professor John Tidy from Sheffield. So we will wait for that study to be published as well. But so far, just on the basis of what CONSERVE has concluded that, and in this study, what they, basically the inclusion criteria were women with a squamous cell carcinoma, adenocarcinoma, low grade, again, small tumor less than 2 centimeters, no LBSI, depth of invasion less than 10. Trial has shown that conservative surgery with conization and simple hysterectomy is feasible in patients with earlier stage low-risk cervical carcinoma. So what are the implications of these studies, CONSERVE and SHAPE, when it comes to trachelectomy? So what we need to know that the patients can be reassured that fertility-sparing surgeries are oncologically safe, and there are good chance of subsequent pregnancy. So we should be very optimistic when it comes to talking to these patients. Often they have lost their hope. They have been planning to get married, have kids, and all of a sudden you say you have cancer. So you need to be very clear about the evidence, and evidence has been repeated on multiple occasions. So we do know that. When it comes to surgical radicality of lymph node dissection and parametriectomy, we need to think about the 2 studies. These 2 studies are not on trachelectomy, CONSERVE and SHAPE trial, but they have some good oncological outcome to suggest that even for trachelectomy patients, you will be able to do less and achieve the same oncological outcome, but less morbidity. And also knowing that the fertility-sparing surgery should only be done in centers that they are capable of doing it, and they're doing it on a regular basis, and they're able to provide data, their own institution data, so they will be able to, help the patient to make an informed decision. Now, in conclusion, I want to say that we talked about whether we could deviate from the level A evidence or not. In Oxford, we are duty-bound, obliged to be compliant with the NICE recommendation. NICE recommendation 2021 was very clear about that we will not be able to do minimal access surgery for cervical cancer if the main treatment, which is wartime hysterectomy, is not allowed for cervical cancer. Actually, definitive treatment, I don't know how this could be allowed to do fertility preservation. Hence, you have to be cautious to introduce that to doing the trachelectomy. Now, I think the laparoscopic trachelectomy or robotic trachelectomy should not be done because we're not doing the same procedure at the moment for definitive treatment of the cervical cancer. Vaginal trachelectomy is something we have started doing And we were really enjoying it because we were able to do the lymph node dissection laparoscopically and then go to the vagina and do the trachelectomy vaginally. But I think we have to be careful that, again, there are some unknown reasons for distant metastases from the LAC trial, and Pedro Ramirez will tell you that in their institutes, they're only doing trachelectomy via open route. But what has changed is with the CONSERVE study, and also I predict with the SHAPE trial, a lot of women that we were offering them vaginal trachelectomy or so-called radical vaginal trachelectomy are going to get more conization, perhaps simple trachelectomy, because vaginal trachelectomy is one of those operations that access to the ureter and reaching and trying to provide a good parametrium is not an easy operation to do, and it's one of those skills that are gradually vanishing in, and it's not part of the routine armamentarium of the gynecologist or gyneoncologist. And then perhaps conization and sentinel node, and the radical trachelectomy for tumors less than 2 centimeters. So for tumors which are really small, we maybe need to do 1 or 2 loops with the sentinel node. And I think that is going to be more helpful for our women, because less if the trachelectomy is not as radical as abdominal or large specimen, then the likelihood of going to labor early, not to get pregnant, and have all those obstetric and gynecological complications I listed would be less. And I have kept abdominal trachelectomy for patients who have large tumors that you do require a large parametrium, large cuff, and I think it's a very effective treatment. And also conization for women who otherwise we used to offer vaginal trachelectomy or simple trachelectomy. But I'm very optimistic that the SHAPE will be probably confirming the finding of the CONSERVE study. Thank you very much.
Thank you very much, Herman. That was a fantastic talk. Any questions, anyone? I don't think there are any questions, but I absolutely agree with you, Herman, in terms of you know, what is safe and to do. I think abdominal trachelectomy or conization is probably the way forward. And anybody who tries to wangle doing it laparoscopically, I think is treading on thin ice. Any other questions or comments, guys? Let me just have a check in the chat box. There's no questions there or any hands up. I think they're all. Oh, was there a hand up that went back down? No. Okay, thank you very much, Herman. That's a fantastic talk. And you've contributed greatly to the day. We'll move on now. In the interest of time, I think unfortunately we're running about 10 minutes behind, and Giannis has got some essential commitments straight after his time. So we'll take the tea break and coffee break straight after Giannis's talk. So I'll let Susie hand over to Susie to introduce Giannis. Susie.
Okay. Yeah, great. Okay, well, thank you, Mr. Soleimani, for your previous talk. Fantastic. And I now welcome Mr. Janos Belega to discuss the challenges of surgical management of recurrent cervical cancer. So Mr. Belega has been a consultant gynecological oncologist for over 15 years, is one of the lead surgeons for the Pan Birmingham Gynaecological Cancer Center. He trained in oncology and surgical oncology in Indianapolis, USA, St. Bartholomew's and the Royal Marsden Hospital in London. And he specialises in cytoreductive surgery for advanced ovarian cancer and surgery for recurrent gynecological cancers. So thank you for joining us today.
Giannis, thank you.
Thank you. Can you hear me now?
Yes.
Can you see my slides?
Yes.
Oh, lovely. Excellent. So, Susie, Sumit, thank you so much for inviting me for this meeting. I've been before to visit you twice in the last 16 years. So I'm trying to. Yes. So I was tasked to talk about pelvic exenteration in 40 minutes, which is almost an impossible task. And I try to kind of introduce you into the management and the philosophy of managing recurrent cancers. Recurrent cancer management is one of the most difficult tasks to find the right treatment for the right patient. Let me just see. So Okay, so I start with a case study. One of our success or unsuccessful stories. You'll decide. She's a 34-year-old lady, and she was diagnosed with locally advanced cervical cancer, and she received the standard treatment of primary chemoradiation therapy. For 2 years, she had been completely asymptomatic, and she was about to be discharged because that's the Birmingham policy. After 2 years, we discharge patients to patient-initiated follow-up. But then I had always had the practice of getting an MRI scan before we discharge the patient. MRI scan surprisingly picked up a recurrence in the cervix, and this was biopsied, and that was histologically proven. The patient was offered a salvage operation, a total translavator pelvic exenteration was performed. Clear margins, we achieved clear margins, and the patient had been doing very well for a couple of years. Then she started having some pelvic symptoms, and unfortunately she was found with one left groin node enlarged and a presacral node, both positive on PET-CT scan, and we removed the groin node. It turned out to be positive, and we then referred the patient to the Royal Marsden Hospital because they were the only place at that time having a cyber knife, and they performed a cyber knife sterilization of that presacral lymph node, and surprisingly the patient showed a complete response. And then I think several years later she was kind of discharged from regular follow-ups. So what I wanted to point out in these slides are the essentials of the philosophy of managing patients with cancer, and how to detect recurrence, how to manage recurrence. Cervical cancer is a rare disease in the Western world, and including the UK. Recurrent cervical cancer is therefore even a rare phenomenon, and therefore there isn't a whole bunch of randomized controlled trials available to make decisions. So we have to rely on retrospective trials, personal experiences, and so on. 30% of patients, if you just see the kind of bulk figures, 30% of the patients with cervical cancer will recur, and most of them, 8 out of 10, will recur within 2 years. The important factors of risk factors for recurrence are the initial stage, how extensive this disease was, whether the nodes were positive or not, whether there was any lymphoscal space invasion on the pathology, how deep was the invasion into the cervix, how big was the cancer itself. So multiple factors do impact on the risk of recurrence. As a general principle of oncology, the first line of treatment should be the most aggressive line of treatment and aiming to be the most efficient. Patients with recurrent cancer are very difficult to be salvaged, and it is true especially on patients with recurrent cervical cancer. A couple of kind of studies just to demonstrate how poorly we are equipped with evidence. For example, after radical hysterectomy, whether to provide a patient with adjuvant treatment, we don't have very strong evidence. We do have some evidence of improved cancer-free survival, but not overall survival. And also, if a failed radiation therapy occurs, what to do then? Whether to offer the patient an adjuvant hysterectomy, or somebody calls them salvage hysterectomy. The evidence is scarce and not very helpful. So where do we find recurrent cervical cancer? Predominantly, they recur at the place where they used to be. So it's the vaginal vault, in the pelvis, in the center of the pelvis, or on the pelvic side walls, the lymph nodes. But unfortunately, recurrence can also occur and develop higher in the parietic area, the lungs, liver, and sometimes even the brain. There have been some efforts made how to identify recurrences earlier. But obviously, cervical smears, wall smears are a complete waste of time. pelvic examination has got some value, but it's not very efficient. And it turns out that listening to symptoms possibly is a very good way of identifying recurrent cancers. Having said that, this is an old evidence, and since there is more widely available access to MRI scans, CT scans, which can pick up recurrence earlier. The reason why I'm talking about an earlier identification is because earlier identification may deem your patient suitable for salvage surgery. And my personal practice is after chemoradiation therapy, primary chemoradiation therapy, I do scan the patients 12 and 24 months after the completion to kind of screen them for recurrence, even if they are asymptomatic. When we have a case of recurrent cervical cancer, we have to take a few points into consideration. Number one is what sort of primary treatment your patient had. Did she only have a hysterectomy or hysterectomy with radiation therapy, or did she have a primary chemoradiation therapy and she still has her uterus in? Where is the recurrence? Is it in the central area or loco-regionally, so i.e. in the lymph nodes, or is it outside the pelvis? Is it a multi-site recurrence, or it's an oligosite recurrence? The size of the recurrence is very important to take into account. Larger, the worse, understandably. And same with the age, around 60, 65 and beyond, patients do have worse prognosis, understandably. Comorbidities are very important to monitor, and particularly the microvascular disease. I'm always warned by diabetes, previous stroke, TIAs, angina, patient being on clopidogrel, and so on. Patient with severe emphysema, COPD are high-risk patients for managing recurrent cancers, especially cervical cancer. If the patient had a previous hysterectomy but no radiation therapy received, everywhere in the world we go chemoradiation therapy is the upfront treatment. Few countries where radiation therapy is not very accessible, primary exenteration is practiced, but not in the UK. Patients after chemoradiation therapy, they are the most common kind of type of patients coming to our clinics with recurrence. And these patients, obviously, if the cancer is centrally recurred, or in certain selected cases recurred on the pelvic side wall, exenterative procedures should be considered. Patients with multi-site recurrences, distant metastases, unfortunately, are beyond salvage by surgery, and they require some sort of systemic treatment. CyberKnife is a kind of targeted radiation therapy, and oligosite recurrences can be treated, particularly if they are lymph node metastases. And unfortunately, patients who are poorly and have a large volume or very extensive disease, they are beyond kind of surgical or oncological help, and they require best supportive care. So my topic is pelvic exenteration after this kind of entree. And let's just put some terms and terminologies into the right place. So exenteration means removing of organs, pelvic exenteration, obviously, from the pelvis. And the exenteration can be anterior, posterior, total, if we talk about the extent anterior laterally. And I explained to you about the role of the levator muscle here. So this is the pelvis, and you can see that posterior exenteration, pelvic exenteration, means the removal of the posterior compartment along with the uterus and the cervix and the vagina. Anterior exenteration is bladder and the middle compartment. Total exenteration is all of them. So when we talk about supralevator exenteration, we consider this operation when the vagina is not diseased or not fully diseased. And we remove all organs above the levator ani muscle. And when we talk about translevator exenteration, that's when we basically transect the levator, we remove the levator ani muscle and everything below. So it's a ischiorectal fossa, and all the pelvic floor basically is gone after this operation. We rarely offer primary exenteration unless there is some fistulous complication and which would delay the chemoradiotherapy. Salvage exenteration means that the chemoradiotherapy failed, there is large volume disease left behind, and you need to basically salvage the situation. And the most common type of exenteration is for recurrence. Rarely we offer palliative exenteration when the symptoms are so appalling that nobody else can manage the patient, but this is a rare kind of opportunity. Exenteration is an extremely morbid operation. There's a large wound surface left behind after the operation, significant complications, grade 3, 4 complications, and unfortunately up to 5% grade 5 complications, i.e. Mortality after the operation. So we really need to find the right patients for the right operation, and therefore we have to ask questions, what was the original stage and extent of the disease, what was the primary treatment, is this patient fit and well, whether this cancer is stuck to the sidewall or not, and whether there's any disease outside the pelvis or not. So basically we have to establish a suitability for surgery from oncological point of view and also from fitness point of view. How do we diagnose and how do we assess patients for exenteration? So obviously the number one issue is to make sure the mass identified on a scan is biopsied and you prove that the patient does have cancer. True cut biopsy is often required, and that's something not everybody is aware of or comfortable of using. I think it's a key part of the diagnostics. MRI scan is extremely meticulous kind of description of the pelvic anatomy when it comes to recurrences, and it helps us to decide whether the patient that the recurrence is resectable. PET CT scan understandably will exclude largish volume extrapelvic disease, which are obviously contraindications for exenteration. Certain centers like the Marsden, they do perform routine laparoscopic kind of assessment to exclude peritoneal disease prior to exenteration. We don't do these in Birmingham. We haven't really found many peritoneal spread in our practice. So there are poor prognostic factors for patients undergoing exenteration. When the tumor is larger than 3 centimeters, that seems to be a poorish prognostic factor. Obviously, if the cancer involves the pelvic sidewall, it's very difficult to achieve clear margin. And clear margin is the microscopic clear margin is the essence of exenteration. Nodal metastases, therefore, are very poor prognostic factors. And what's very important is that if the patient recurred very quickly after the primary treatment, that usually indicates a rather aggressive course of disease, and it doesn't seem to be. They don't seem to be the best candidates for operation. I mean, technically, you can perform the operation, but usually they recur, unfortunately. So resectability, I mean, can we cut it out? How do we assess this? It's a radiated field. It's completely rigid by radiation, fibrosis. Very, very difficult to assess by an examination under anesthesia. Classically, they said, if the patient is moving with the tumor, then it's not resectable. But this is not the case nowadays. And I was trained at the Marsden differently. And the trial of dissection is obviously the most important factor deciding on resectability. So the traditional paradigm for exenteration used to be just operate the cancers, developing in the middle of the pelvis, in the middle compartment, not going out of towards the side walls, spread to the side walls, causing sciatic or hydronephrosis, hydroureter hydronephrosis, lymphedema had been absolute contraindications, and still are, up to a certain degree. Obviously, if somebody has got lung metastases or else, these are cases not for exenterative procedures. Having said that, there are cases when pelvic sidewall involvement is to be considered for exenteration. And that's a kind of relatively newish kind of paradigm from Germany, from Professor Höckel. And this is the laterally extended endopelvic dissection when basically we are talking about cancer recurrence which invades into the pelvic sidewall lymph nodes away from the sciatica nerve, and you can remove them with the obturator muscle included, and therefore you kind of provide patients with an R0 dissection, a clear margin, because you included some surrounding muscle. This is just a picture of the representation where these lumps are, which can be resected. If this lump was sitting close to the lumbosacral plexus, obviously the resection would not be complete and microscopically clear. So selecting patients, obviously you try to find a medically fit patient and the oncologically suitable patient. Adequate diagnostics are done. And what's very, very important, and I learned it through my practice, there are patients who are not fit psychologically for exenteration. Exenteration results in a major change in the body kind of image, with no vagina left, 2 stoma bags, and this may pose a major kind of stress and pressure on the patient's psyche. So when we talk about the exenteration as an operation and we open the abdomen, we've got 3 phases of this operation. First, as always in oncology, is explorative phase. You have to explore the peritoneal cavity, and if you find any disease or any lumps, you have to send it for frozen section to exclude any malignant changes. The resective phase, we always aim to achieve an R0. R0 means that clear surgical margins on the microscope, and that is the only situation when patients can be provided with long-term overall survival benefit. And the third phase is the reconstruction. So imagine after removing the rectum, the bladder, everything, the vagina, we have to reconstruct the urinary tract. Most commonly we use the small bowel to provide patients with an ileal conduit, but the large bowel can also be used. We have to provide the patient with a colostomy. And if the levator ani muscle is removed, then repair of the pelvic floor either with flaps or with some biological meshes can be necessary. And outcomes of these kind of horrendous procedure, because they are quite morbid procedures with well-selected cases, and my favorite paper is from the United States, from the Memorial Sloan Kettering. If you select your patients well, around 50% long-term survival can be achieved. And in fact, in certain histological subtypes, like adenocarcinoma, you can achieve higher. But obviously, it's only if the resection margin is R0. Hence the reason selection is extremely important. Because don't forget, this is a very, very comorbid, it's a very, very morbid operation with, I'm talking about grade 3 and 4 complications. So it's not just fever or UTI, but severe complications, including death. And the survival, these figures, this paper just basically got all of the publications and compared the old ones with the new ones, and on average around 35% 5-year survival was achieved. But even Brunswick's paper, and 1957 papers were included in this. So nowadays 50% overall long-term survival, 5-year survival is quoted in our clinics. Susie, I'm just running out of time, I think. Am I right?
You've still got 5 minutes. Yeah.
5 minutes, God.
Yeah.
So excellent. So it's just a very quick case report. This is a failed treatment of radiation, chemoradiotherapy for a stage 2 vaginal cancer who underwent a pelvic exenteration, adequate.
Janice, you've got 10 minutes, so don't rush if you don't need to rush.
Okay. It's a 7-minute video, but
yeah.
What we could do is the video could run and I could answer questions if you.
That sounds good. Yeah.
So basically, you need to have adequate instrumentations and retractors to have adequate exposure. As you can see, Having said that, nowadays robotically or laparoscopically you can perform exentrations as well. And this operation went pretty well with 600 mils of blood loss, no intraoperative complications. The margins were clear. She had some kind of the usual perineal fistula leakage from the perineum was the most kind of disturbing complication. Luckily, strangely, this patient must have had a field change of some sort, because she later developed vulvar cancer. And then, unfortunately, a few years later, she recurred. We did another kind of exentrative procedure, and then, unfortunately, again recurred. So I'm trying to So here we are. So this is a video recording of a total pelvic exentration, an open setting. And as you can see, I made it a little faster when I edited. So please, questions. Sumi, I can't see the questions because I'm watching this video here.
I'll put the chat in. Are there any questions for Jonas? Please put them in your in the chat box, or if anybody wishes to raise their hand, please raise your hand.
So whilst questions are coming, most important thing is post-radiated tissues must be challenged and handled very carefully. You saw this special gun. It was a ligature impact, but you can find other types of instruments. They have brought a complete different ballgame to the exentrations. The blood loss is minimized, and the operation is like within hour and a half, 2 hours, you can do the resective phase. You open the pelvic side where you identify the structures. You can see the round ligament here. This is the special gun, which is safe and efficient utilization of theater time. You then have to basically extend your incision because you would like to remove the bladder. IP ligaments are taken. Ureters at one point will need to be transected. This one here, this is the retius space. This is the anterior part. So on the top you can see the symphysis pubis, and we are pulling the bladder down. You have to create this plane. That's possibly the plane where you have to be a little bit more careful, because a plexus around the bladder is always posing some bleeding risk. But if you're careful, handle carefully, and use these special machine guns, then it's fairly bloodless surgery. So any questions in the meantime?
There's George. You want to just come in here, George? If you want to unmute yourself and ask your question, George Ugwo.
So in the meantime, we have reached the pelvic floor. Okay, just you can see anteriorly we reach the pelvic floor, and for just before the question comes, this is the parametrium. All right, so paravesical space, pararectal space, and between is the classic parametrium. For those who imagine what this parametrium is about. So please, a question, yes?
George, you want to ask your question?
Oh, hi. I was just going to ask about the experience with adhesional bowel obstruction following exenteration, and what the management plans would be, considering whether conservative versus laparotomy. What
adhesional bowel obstruction?
Yeah, following.
I have to be honest with you. Complications, the ones we suffered with were leakages, particularly urine leakage, because the radiated bowels, the radiated tissue doesn't heal well. And you can see here on the picture, we just reached the pelvic floor muscle. Okay, that's there. I will show you in a moment the levator muscle. I will point towards it. Yeah. So obstruction. This is like you can have obstruction after a cesarean section or a cholecystectomy or any operation. So this should be managed similarly, and usually it is conservative if you can manage it conservatively with conservative measures. Often the radiology contrast material is very helpful to unblock blockages. But sometimes you can get an obstruction and requiring laparotomy. This is just you can see here under my hands is the rectum. This is the mesorectal plane, and we are basically dissecting this of the sacrum, and we are reaching down below. We are reaching the pelvic floor. You can see there the pelvic floor muscles. Any other questions?
Yes, Jayshree's got a question. Jayshree, do you want to unmute yourself and put your camera on?
Hi, thank you so much for your talk. I was just wondering, is there any group of patients you would consider for primary exenteration? For example, if you had a cervix cancer patient with quite a large fistula that would, be a relative contraindication for radiotherapy. Would you consider them for?
So exactly, that's what I was talking about. That particularly in Eastern Europe, where radiotherapy provisions are not as great, they use for stage 4A, so bladder invasion, they use primary exenteration very often. But in the UK, we have done one of these kind of palliative primary exenterations. Exactly what you mentioned, the patient developed a double fistulae, and she would have needed an operation. She was basically having a pelvic sepsis because of the fistula. So we treated her with antibiotics, and we took the opportunity and did a total exenteration. It was a stage 4A disease invading into the rectum and the bladder.
Great, thank you so much.
Thank you. Newman?
Thank you. So you can see now, I went back and we just chit-chatted a bit. This is the pelvic floor muscle. The levator ani is transected. You can see there down below. For if you've done obstetrics from the other side, you must have seen the ischiorectal fossa yellow fat. So that's how we enter. And this is the second phase, the perineal phase. If you you don't need to watch it. So this is maybe a bit disturbing for certain people. So we have to basically complete the resection, match up the resection, and meet the inside exenterative planes from the perineum. Any further questions to me?
Human, do you want to unmute yourself, please?
Apologies. Yes. Well, beautiful surgery, Yanis. I was really enjoying the operation. Just wanted to tell you that I use also LigaSure Impact. I think LigaSure Impact has revolutionized the radical operation and exenterative operation. It's my favorite instrument, and now we are able to carry out very extensive operation with a minimum blood loss. That's one thing. Many thanks for sharing this. And also, I think one of the question was, what we would do with the empty pelvis syndrome. I think one of the problem we do face, which would put the patient at the risk of fistula, is when we have done extensive resection, especially some of these patients, as you rightly said, would require LIR as well, which is basically will be left with a very larger space to fill in, even with your VRAM, or you might have struggled to fill those empty spaces. So I think that was a question I understood someone asked from the audience. Janis, what would you?
It's a very, very difficult one. So basically, we do big ovarian cancer operations, 4-quadrant, and somehow they don't have the complications. These poor ladies with the pre-radiated tissues, we basically peel off, and they've got a large raw surface in the pelvis. What we do in Birmingham is we bring down where are you guys? So we bring down a Omental J flap. So we've got a few solutions. If the gap is very big, we can ask the plastics to bring up some flap and kind of fill the gap, but it's not going to fill the gap a little bit higher in the pelvis. So I myself put a stitch, a biological mesh, a porcine mesh to the kind of levator ani margins, and I bring down the omentum and try to fill that empty space. That's how I manage it, to be honest.
I think that's a brilliant idea. And just one thing I shared that we have done with the sarcoma team as well, when we resect often we have to go very lateral, not for the cervical cancer or gynecological malignancies. We have left the breast implant. And that's quite unusual to think of, but actually has worked really well. And we didn't have to be worried about, just something to think about to be added to our
No, it's a very good idea. Thank you. Thank you.
Yes.
No worries.
Great.
No.
Fantastic. Thank you. Any other comments or questions? Thank you, Jonas, for your third appearance in so many years as a maximally invasive surgeon. You know, I love it. We will get you back for the ovarian, no doubt.
Yeah, I remember the first time it was Andy Phillips. Then he was a registrar. I invited a very aggressive surgeon.
Panel, I remember you invited me.
I'm not aggressive. I try to be a very pleasant person.
No, not saying that in any way. Maximally invasive. Thank you very much for your time, and sorry for running a bit late.
Please, okay.
Fantastic, thank you. Would you send us across your presentation, and would you be able to happy to for the, not the video obviously, but the slide to go on the
yes,
the website?
I can send it to Susie if it's all right.
Susie or me, yeah, either way, yeah, that sounds good. Cheers. Thank you, Jonas.
Thank you. Have a good weekend.
So guys, we're running. We need probably a 10-minute coffee break. So I think if everybody just has a bit of a stretch and a bit of a coffee break, it might be worth people putting their cameras on. It'd be quite nice to see people still out there and see the vast numbers there are at this stage. Claire's there, so if you'll put your cameras on, and then we'll get to see people while they're still here. But please stay for the last talk. Mary will be with us, so we'll just have a 10-minute break, grab a coffee, keep your cameras on, and maybe we can chit chat to some familiar faces across the way. Let's see how many cameras we can get on. How many of you are still awake or still there? So there's loads, but we've got in the region of about 200 still online. So let's see if we can get most of you up there. And so if you want to have a stretch and go to the loo, then or grab a drink, please feel free to do so. But it's quite nice to see faces and who's out there without just the names there. So lots of familiar faces, lovely.
Abdul, can you hear me? Yeah,
I can hear you. Yeah.
Silly question. I just didn't understand this extrafacial colpotomy still.
I think they're just saying that you open things from down vaginally rather than abdominally, so you get the amount of time the peritoneum is open is minimal. So you're not getting the cervix floating around, and the gas is not potentially spreading things. So yeah.
So the extrafacial really doesn't matter. It's still a peritoneal entry.
You're still going to have to enter the peritoneum at some stage. Yeah.
Okay. All right. Thank you. I'm going to turn my camera off for the moment.
That's fine. So if we aim to come back in, everybody can leave their cameras on. But if we aim to restart at 16:30, is that okay with you, Mary? Is that okay? Yep. Yes. So we aim to recommence in about 7 minutes time, and then it's been a fantastic attendance. I just hope everybody just stay right till the end, because it's been a fantastic day. It's been great seeing everybody. So I'm going to turn my camera off and mute myself, and then we'll go for a coffee and maybe turn cameras on at the end again.
Can I ask anyone who's there if you can see the main slide, or can you see the slides and the notes? How does it look?
Just the slide.
Just the slide. Perfect.
Yeah.
Good. Thank you.
Hello.
Hello. Are you joining in?
No.
Just having a look what we're up to.
Yeah. Bye.
Bye.
Okay, Susie, are you there? I think we're just waiting Susie, so we'll just give her a minute or so if that's all right, Mary, with you.
Of course, it's fine. It's fine.
Hi, sorry about that.
So if we can recommence the next session, so now that Susie's back, Susie, I'll hand over to you to introduce Mary.
Okay, well, thank you so much, Dr. Lewis, for your patience. I know we've been running a bit behind this afternoon, so we really appreciate you sort of putting up with that. So our next and final speaker is Dr. Mary Lewis. So Dr. Lewis is a consultant in palliative medicine here at the Royal Derby Hospital, and she's going to talk to us about the very important topic of palliation in cervical cancer. Dr. Lewis has been working in palliative medicine since 2003, with experience working in specialist inpatient units, as well as of being a member of hospital advisory and community teams. Dr. Lewis has more recently, since 2020, been appointed lead for the community palliative care team, and has been a truly valued speaker at our symposiums previously. So thank you, Dr. Lewis.
Thank you. Well, oh, sorry. Thank you for inviting me and closing this really, really impressive day. So I'm going to run through both elements of recognising and managing the end of life when our treatments can no longer hold the cervical cancer. So in this talk, I'm going to go through some language around terminal illness and try to give a bit of clarity on prognostication. And we're going to look at the main symptoms and what can be done to help with a holistic approach. So the first step in recognising end of life is to understand what we actually mean by the term end of life. And the GMC devised a new UK definition in 2010. And the concept to note is that end of life is now anywhere between the last year of life and the last hours to days. So this slide isn't cervical cancer specific, but it reminds us that the advanced, progressive, incurable condition, i.e. cancer, may not be the only issue that these patients are facing, and that we have to put the whole patient into our minds when considering what end of life looks like for any one individual. And that crises and catastrophic events such as sepsis, PE, hemorrhage can obviously change prognosis rapidly, whether those problems are treated or not at the time. So talking about prognosis and how we recognise whether somebody is dying, I would say no health professional will ever hold you to account with prognostication, but the patient might. So always be careful to be as honest as possible, but avoid using numbers. So we try to use terms like whether the prognosis is hours or days or short months or seasons, or even a short number of years should all suffice. Because in cancer, the lottery of treatment response affects all of our abilities to predict prognosis in the individual. But at the very least, we have to be really clear to everybody if the patient is curative or not. And sometimes that's a really difficult conversation. Because we know that bad news will cause distress, but it allows the patient to adjust their goals and their expectations and come to terms with their loss, sometimes away from your clinic room. And there are many, many prognostic tools that have been developed in cancer. But what we know is that clinical intuition is often as good as these prognostic tools if we're honest with ourselves as clinicians and doctors and nurses. And one way of trying to use the clinical intuition is to ask this question that's become known as the surprise question, i.e. would I be surprised if this person in front of me was to die in the next few months or the next few weeks or the next few days? And obviously some people surprise us and live longer than expected, but if we pull together clinical and social facts and the future looks really uncertain, at the very least we need to start communicating the uncertainty. So this slide expands on what feeds into your clinical intuition, because it's important to notice the changes are happening and just to ask the questions, how are you coping at home? and to ask questions beyond the basic performance status. So things that will feed into your intuition are the speed of decline and the amount of increasing needs that that patient is having. Thinking about the comorbidities, thinking about weight loss, thinking about nausea, vomiting, how much the sort of inflammatory symptoms are happening in the background, how many repeated unplanned or crisis admissions they're having across different areas in the hospital, whether they are having a sentinel event, so they've had a serious fall, maybe there's depressed or very low after a bereavement. And don't forget albumin, which isn't just about nutrition, it's often a significant marker of poor reserve in our cancer patients. So whilst the complications on this slide can be treated individually and may not by themselves be determiners of being in the last year of life or of specific prognosis, from my experience, complications start to build a picture of disease progression and frailty and reduced reserve. And they're often the events that enable us to start reflecting with the patient about disease progression and introduce conversations around limitations of treatment and what the next steps may look like. So now we will start to move on to management of the patient at the end of life. But just last words on prognosis is some wise words where I read that sometimes when somebody asks you that question of how long have I got, and inside you feel helpless or any other emotion like fearful of causing distress or worried about the pressure of time on how long it's going to take to answer that question, or panic that actually you haven't got all the facts because you haven't asked the questions or gone back through the CTs or looked at the blood results. Sometimes instead of trying to answer the question, how long have I got? Actually, the unspoken question might be, you and I know that I haven't got long. So what should I do as a patient? And how can you as a health professional start to help? So sometimes just starting a conversation with, I'm not sure, but I'm going to start looking into things and I'm going to try and work it out. But what is it that you need from me? Sometimes is as helpful for that patient as trying to throw a number out into the conversation. So managing the end of life. So we're going to run through a little bit about symptom burden, what you can do to help, but also who out there is supporting you as a health professional while you're trying to support the patient. So you'll be familiar with the fact that cervical cancer patients have quite a range of symptoms and they have some quite complex symptoms that can be quite challenging for them and health professionals. So pain, I mean, a whole talk on pain is beyond the scope of this talk, but I'd remind you of some very sound principles, which is take a history and really listen to it and try to listen to all the different pains that they're getting, because with pelvic disease, obviously, they may have some direct tumor pain, they may have some neuropathic pain, they may have some colic and some spasm pain, and they may have pain unrelated to things going on in their pelvis. So just try and start correlating the pain with the scan. And when people have got more than one pain, we might need to address each pain in turn. And it might be that we need to have different pain approaches for different pains. So use the WHO ladder. But don't forget, you might need to use adjuvants for neuropathic pain, for tenesmus, for bowel spasm, for inflammation, or even consider infection, which can be really hard to treat with analgesics, but can respond really well to antibiotics. But when you do start analgesic for pain, we need to have really clear communication about who's going to review the drug, and share expectations with the patient about what you might be able to add in next. Put that in a letter. Try and make sure these letters are prioritised somehow, so they're not sitting in the secretary's list for the next 2 or 3 weeks. And remember that as the patient starts to struggle with tablets, or if there's a massive tablet burden, that sometimes we rely on patches. Sometimes with renal failure, we've got buprenorphine and fentanyl patches. And if they've got issues with swallow, there's always the option for syringe drivers. But in the community, that's often managed best with the district nurses' support. So because we're talking about cervical cancer, it seems that vaginal discharge can become one of those difficult things for people. It becomes quite embarrassing for people, and sometimes it makes people quite socially isolated. And again, I think there's no clear solution, but always remember your bacterial infections, and that even though we can't always permanently eliminate the bacterial infection, that a course of antibiotics might get on top of it for short term. And sitting in warm water to clean, maybe putting some dermal in the water, which has got some mild anti sort of bacterial effects. Protect the skin around the perineum by drying after bathing and applying a barrier cream. Ventilate the room, and often patients quite like using essential oils in a humidifier. And continence pads, if you refer to the continence team, obviously the pads may fit better, or they may provide with some charcoal to put in the pads. In our trust, we use metronidazole 400 or 500 milligrams twice a day for 5 days for vaginal discharge, but looking through the papers, international practice seems to vary quite considerably. Fistulas have been mentioned quite a lot through the day. We sometimes find that our patients are getting a build-up of a pressure symptom in their pelvis, which we're really struggling to manage the pain. And then suddenly the fistula breaks through and the pain may improve, but they've got themselves now an even bigger problem. So psychologically, it's really debilitating for patients. They find it really, really hard to cope with. The fistula can't be repaired. I understand that very rarely you got the option of sort of exenteration, but that sounds really difficult. We don't do short pack vaginas, but it's clearly you wouldn't want to do that in the presence of a fistula. I've contacted one of our colorectal surgeons to say how often do they have success with fistula repairs, and they said they're always happy to see people to consider end or defunctioning colostomies, but obviously so much depends on healing and depends on albumins and depends on functional status. So again, sometimes we're back to thinking about, are there local infections? Do we need to give antibiotic courses? Can we divert anything from the ureters with ileal conduits or bilateral nephrostomies? Or ultimately, do we need to just go in and listen to the distress and try and help them with continence issues, or such as getting the right pad, and with any help that can be for things like laundry and putting in extra support at home. The vaginal bleeding, there are increasingly sort of nervousness around stopping anticoagulants in the presence of bleeding. I still see a lot of people who are being anticoagulated for things like AF whilst they're having active bleeding from cancer. So I tend to always say that we need to be a little bit braver sometimes with stopping anticoagulants if we think somebody's in the last month or so of life, and actually just treat the problem in front of us rather than anything prophylactic. If it's for a PE, go back to the CT and have a look whether it was a subsegmental PE, how symptomatic the patient was. Can we take a risk on stopping the anticoagulants? Tranexamic acid, I think, is a really excellent drug, and in palliative care, we're starting to use it topically on any gauze for any localized skin bleeding. Orally, we try to load people with it, but bearing in mind it takes 2 hours to work. So if somebody's got bleeding at end of life, it's about being sure that you've got time. But equally, we know it can be used intravenously in hospital, but likewise, it can actually go into a syringe driver in the community. So other symptoms, fatigue or weakness, I tend to refer to the community physio or OT to think about energy conservation techniques. We do use dexamethasone at low dose, 2 to maximum 4 milligrams for fatigue, but really it works best if there's evidence of an inflammatory component. And I would generally try and limit it to 2 weeks for fatigue. Otherwise, we find people end up on it with very little benefit. Edema. Edema is something that can become really quite distressing. It's often multifactorial, a combination sometimes of venous hypertension, immobility. In modern society, quite often there's an element of obesity contributing, but obviously the cancer-related issues and surgery, radiotherapy to the lymphatics, resection of the lymphatics, low albumin, lymphatics being full of tumour, and venous compression in the pelvis. And so we have a clinic in Derby where we take cancer and non-cancer patients, and we manage lower limb edema. We also manage genital edema in clinic. So often it's a case of starting with emollients, seeing what compression we can get on people, whether that's measured, prescribed compression, or trying to help people with lycra and some sort of support. Cycling shorts almost for the pelvis is sometimes more acceptable than trying to get people into tight compression for the pelvic area. There's European evidence that you can compress over a DVT after 5 days of anticoagulation. So compression doesn't have to come off as long as somebody's been established for 5 days on an anticoagulation for DVT. And in general, I would say avoid diuretics for cancer-related edema unless you've got evidence of organ failure contributing. So have a look for organ failure in the form of renal, liver, or cardiac, but otherwise your diuretics might cause more harm than good. So again, if your patients are getting hydronephrosis at the end of life, always stop and think about a nephrostomy. I think in the past they have sometimes been offered as a little bit of a avoidance of facing end of life, but actually they have got significant burden attached to them. They affect sleep. They have to be changed 3 monthly. They have an infection risk. The tubes get displaced. But actually, it's a question of saying, what are we trying to achieve by maximising the renal function in this patient? Is it a bridge to getting them to chemotherapy, or are we trying to delay death from renal failure? And if that is our aim, have we actually had an honest conversation with the patient that we're giving them this tube to buy them a few weeks? And do they really want those few weeks? And what if they're very fatigued, if they're tired, if they're in pain, that actually they may need you to contain that. Is it because they want to stay on their non-steroidals, and actually a tube to address renal function might enable them to stay on non-steroidals? There's reasonable reasons. Other things for advanced cancer and nutritional issues. Obviously, we tend to say to encourage as wide a diet as the patient can tolerate. And the dietitian can be a support, but sometimes it's a case of acknowledging that cachexia will follow, fatigue will follow, and it's not all about how much nutrition is going in. And that in the last days of life, hydration is not actually a goal for the last few days of life. And that getting some fluid into the mouth for help with mouth care may be a more important goal than actually a physiological hydration. So trying to adapt what people are drinking from, being practical about maybe using some teaspoons, but also maybe using just some gels or saliva spray to keep the mouth moist. And we often spend time reassuring families that actually now the body needs minimal fluid because the organs are slowing down. And in palliative care, we sometimes see that a little bit of dehydration in dying patients does have therapeutic value. There's reduced problems with incontinence, there's less nausea and vomiting, there's less gastric secretions, there's less pulmonary secretions, and actually there's some analgesic effects at the end of life by becoming a little bit less well hydrated, as the inflammation and the swollen distended organs sometimes have a chance just to relax a little bit. So, who can support you as healthcare professionals out there looking after these poorly people when you've tried so hard to keep people alive, but you may still be an important health professional to them? So my advice would be keep your community partners informed throughout the process. So look at what we can do to support you from hospital, documentation and processes, and the community, and from what the palliative care team can support. So in the UK and in Derbyshire, we have various support areas that I will run through, although some are more local than national. So Macmillan, throughout the country, will support patients with benefits. And DS 1500 is available now for less than 12 months of life. And that can be completed by the GP, or the Macmillan team can support that. And that's a different team to palliative care. That's supported by the charity Macmillan directly. They can arrange a patient's blue badge, they can give travel insurance advice, and they can give general information. In Derbyshire, we have a local hospice who will help with family counselling, that they provide a drop-in day centre. They can do day sits and night sits when clinically needed. And they will also have a roaming service that can go out to the patient's home and give subcutaneous drugs at end of life, as well as 111 and the district nurses providing that service. In Derbyshire, we also have symptom management and syringe driver advice on an amazing resource, which is our end of life toolkit, where all Derbyshire services for the community for end of life are summarised under one website, which is free to use. And also any needs to get district nurse, OT or physiotherapy can be referred by phone or email. But when you've got the patient in front of you and you get any cues about the patient's wishes, try and clarify them and get them into a letter to the GP, because any important discussions that you have in clinic that can be transferred over to the GP, you will find does carry through to the community. People do see those letters. The district nurses do read them on the community service of System 1. I think also keeping the gynaecology nurse informed, because they will continue to hopefully have a relationship with the patient at home. And do use the community palliative care team for people with persistent symptom issues or really complex psychosocial issues that you're struggling to manage. Within the hospital, there is help to try and streamline things 24 hours a day, so that when the medical rounds have seen the patient in the morning, that you have clear communication so that your decision making follows through for the next 24 hours. So in the UK, there is a system called AMBER, which is an acknowledgement of uncertain recovery that was developed at Guy's and Thomas's, where you spark a chain of conversations to acknowledge with the patient and their family that you think they might not recover from this event, and you consider whether they need resuscitation, conversations to be done, and you start to think about limits of care. It's an acknowledgement that recovery is uncertain. And and in our area, we know that about 2/3 of people who are identified with this paperwork will die during that admission. So clearly documenting uncertainty. And that care is improved to that individual, got a bit of a cough, if all members of the team have an understanding of the expectations of care. So what really helps is senior clinician leadership, so that all the rest of the medical team can follow through.
Are you okay, Mary? Do you want a minute?
I'm all right. I'll have another.
Sure.
Mm.
Take your time.
That's all right. And then again in the UK, we have a system where we talk about fast track discharge. And what that refers to is fast tracking the decision to fund the care package in the community. So that when you think that somebody is in their last 8, 10, 12 weeks of life, their whole funding for either a nursing home or a full care package at home, which can be 2 calls 4 times a day, then supplemented by the charitable sector, that those decisions get made without further assessment. It gets made purely on the word of the referrer that the patient is now in their last weeks of life. So the funding will all get agreed for that care package or the nursing home in less than 48 hours. But obviously allocation of the care package or the nursing home takes as long as it takes. But while you're doing that, you need to think about the discharge summary and what does a patient with only a few weeks to live needs to have written on that discharge summary? And can we get the anticipatory drugs out there? And can we think about making sure that they have a respect form, that they understand what their options are if they want to die at home? And that somebody's had a discussion about whether they would want to come back into hospital, acknowledging that they haven't got long to live, and what would that look like if they did come back into hospital. And then getting all of that onto the discharge summary means that those conversations are much more likely to lead to the patient having their wishes followed through. And we have lots and lots of data in the UK to show that documenting the discussions causes the patient's journey to reflect their wishes much better. So our palliative care service in this trust and in most trusts in the UK is a broad service that covers palliative care wards. It covers all inpatient teams. We offer support out in the community, and we run palliative medicine clinics. And we always ask for the parent team to do as much as possible within their confidence levels, whether that be symptom control, conversation, liaisons with community service, but to refer to us when the gynae-oncology CNS, or the gynae consultant and the rest of the team can't manage, because we're happy to guide, and at the end of the day, it's the patient that we're trying to look after. This is a busy slide that I don't expect you to be able to read, but it reflects that we know that community services are complex. This is the slide that reflects all the community services based on a red, amber and green for speed of response out in the community. So as a community palliative care team, we're quite used to navigating all of this, but people who are based solely in the hospital, it's a little bit of an unknown world. So do utilise your district nurse or your palliative care nurse if you need any support. And then these are just some wise words really to finish with. If you do find that you're somebody that just finds conversations about prognosis, about death and dying with people really difficult, and you find you'd rather avoid them, then actually these are just two books that are really engaging and really interesting, that reflect on how we deal with death and dying. So Kath Mannix is a palliative care consultant, and she talks about normal deaths and what death looks like at the end. And it's really just to kind of remind everybody, health professionals and the public alike, that what death and dying is like, so that we can have those conversations with patients about what to expect in the last days and weeks of life. And Atul Gawande, you may have heard of, he's a surgeon from America who took some time out to really stop and reflect on what modern medicine and what surgery can offer, and where that stops, and what we need to be able to offer more holistically. And he learned to ask, that was it, he learned to ask his dying patients 3 main questions, which are, what are your main concerns and biggest fears? And what are your most important goals? And what trade-offs are you willing to make? And he found those 3 simple questions helped him navigate end-of-life discussions with patients in clinic. So, in summary, recognising deterioration can be done with clinical intuition and marrying that up with the facts. And that managing the end of life is complex and difficult, but it's always a little bit easier if you have an honest relationship with the patient and you make decisions relative to prognosis and risk and benefit. So that's it. Thank you.
Thank you, Mary, for a fantastic talk. That was very enlightening. We'll open the floor up to anybody who wishes to ask a question. Is there anybody who wishes to ask a question, please? Ask your questions now. Any hands up? I think as clinicians, we always want to cure patients, and I think doctors and nurses and healthcare professionals are programmed to do that. And so I think people often find these conversations difficult. How do you manage symptoms that we don't know the treatment? There's easy treatments. I think some of your palliative care slides there are very, very useful. And I think as clinicians, we should take those on board. Symptom control rather than cure, you know, that vaginal discharge, that bleeding. I think that's very helpful. I think the discussions about end of life are very important. I think you know, where people want to die, how they want to die, I think are important. And just from a personal level, you know, I'm not sure whether people often want to die at home or think they want to die at home, but I think the other side of the coin is that there's also the relatives there, and people have to take that into account. If there's young children at home, if there's a husband or wife, are they going to be able to cope with that relative having died at home? What are your thoughts on those discussions, Mary?
I guess we see all sorts of families with all sorts of preferences, and unless you ask, you just never know. And we see young people with gynae cancers and little toddlers who manage to die at home because they've managed to rope in enough support from friends and family, and they've started that conversation early, and so that everybody's able to come together. But equally, we often end up admitting people to our palliative care ward, and we have quite a stream of young people who we kind of almost have a relatively relaxed admission, where if they might want to be in for a few days and then go home for a weekend to be with children and then come back in because they're so weak they can't stay at home. Generally with the young people, I try to be as fluid as possible with the admission. So I would say that if you start the conversation early, allow the distress, allow the tears, people can work through the distress and then start to have the honest conversations in time for everybody around them to get their heads around what's possible, what's the art of the possible, what's not possible. Let's be honest and let's try and support each other. If you leave the conversation till the last day or two or week, there's no time to adjust, and sometimes the crisis is inevitable. And
any other comments or questions? I think it's often the clinicians who, as you say, I mean, are often uncomfortable having these discussions, but they're discussions that need to be had. And I think that's been a very enlightening talk. I think we've all learned something from that. Any other questions, guys? Thank you very much, Mary, for a fantastic day, I think, and a fantastic talk. I think all that's left for us to do is to bring an end to the day. If everybody can turn their cameras on, it'd be nice to see. Can you stop? Can I ask you to stop sharing, Mary, if that's okay?
Yeah, of course.
But if everybody puts their cameras on, can I just thank everybody for all the presenters for doing a fantastic, doing fantastic talks and making this a good day. Can I thank the organisers, Susie, Jane, Aisha and Mark for putting on a fantastic programme. For those of you who haven't haven't registered and have just joined via a link, can you make sure you put your email addresses in the chat box so that we can make sure that we can send you all a feedback form. Jane will email out a feedback form, which will be basically Microsoft Teams link. Please be patient because it is obviously on a Friday afternoon, on a week, Friday afternoon, and so those will come out to you by early next week. Once we receive the feedback forms, then we'll send you an attendance certificate. Please add any comments either in the chat box, but certainly in the feedback forms. Tell us what you thought of the day. What was useful? Was it good? Was it bad? Was it horrible? Whatever you'd rather say. And all that's left me to say is thank you for participating and being here. To have 200 odd people still here on a Friday afternoon at 5 o'clock, and I think at the most we've had about 350 people registered, with 250 on at any time, has been great. So thank you all. As for next year, the programme is already set in place. The date is already set in place, so you can register now for next year, and then there's no excuse for you, all of the colleagues who are emailing me on the day and saying, can we register now? So try and register early, please, and we'll obviously advertise this locally, nationally, and internationally. And the number of international delegates attending has just grown. So thank you. Any other comments or queries? You can unmute yourselves and say whatever you want. But no, thank you.
I just want to thank all the speakers for joining us today. I hope everybody feels that we've sort of gone through a journey updating on cervical cancer with a really poignant end to the day from Dr. Lewis. So yeah, fantastic talks. Thank you all for sharing your expertise and supporting such a great educational event. And thank you to all the delegates for joining us today, and some really great questions and discussion as well throughout. So hopefully you all enjoyed. So thank you, and see you next year.
Fantastic. Thank you very much, everybody. If you can wave as you go away and log off, that'd be brilliant. We'll stay on until the last person, and we'll see who's asleep and has just been logged on and just staying on, because that is fairly common, or can be. People, you know, sorting other things out. Okay, but it's been lovely seeing you all. See you guys. Have a good evening. Have a good weekend. Thank you for all your help.
Thank you, Sumi.
See you guys. Thank you, Onig. Sammy, all right, still there? You okay?
Yes, I've dipped in and out, and not seen as much as I wanted to see today, but what I did see was absolutely fantastic, well organised, and the presenters were amazing, so thank you.
Ilham, nice to see you as well.
I don't know how to do it.
Susie, I sent you an email.
Okay.
All right.
Thank you, guys. You just log off and wave as you log off. That'd be lovely. Okay. Fantastic. See you guys. See you, Ilham. Fantastic. See you guys. You can sign off, Yasin, if you want. So shall we just... Is that everybody? I'm trying to think. That's fine. Should we log off and then we can try and remove people from the meeting? Is that right? We're just going to sign everybody off, guys, one by one. Just if you click on the right side and just say remove from the meeting, guys. Yep. Mark, can you help with that as well? If you start at the bottom, I'll start at the top.
No problem.
And then we can, that means we can then finish the recording, you see, as people, as the meeting is then complete. Don't know how many are left.
15.
That's all right, we're getting there, 10. Okay, so I think that's everybody.
Yeah.
Well done, team. Fantastic day. I think everything went smoothly. I don't think there's anything else we could have done. I think we're pretty much on time, considering, and you know, to have 163 or whatever there was at the end, you know, 200 odd people still there on a Friday afternoon speaks volumes, really. So well done.
Yeah, no, absolutely, because I think, you know, people will have dipped in and out. So
yeah, people are dipping in and out.
The whole time, I think even more people were sort of in and out as well, which is great. And I think, yeah, I think we sort of got back and on track in terms of time. But the afternoon talks were all excellent. I mean, they all were, but, you know, excellent. So I mean, it just, I think everybody was more than happy to stay a little bit just to get, you know, just to hear the last of the talk. So that's really good.
Fantastic. Well done.
Well done, Jane, for all
well done,
the
Jane.
admitting and banishing from the meeting. Well done. More admitting than banishing, I think.
And Mark and Aisha, well done as well. Right, guys, shall we log off now? Call it a day.
Yeah.
If you log off, and I'll log off at the end, and then we'll. If you want, I'm just round in the office. I don't know whether are you popping around, Jenny? Are you going straight home?
Yeah, I'll come round to you.
Yeah. All right.
Okay. Thank you very much, everyone. See you
Cheers,
later.
Mark. Thank you for your help. Thank
Okay,
you.
thanks for your help.
Bye. Bye.
Okay, see you. Bye, bye, bye. Okay, we're going to log out, yeah?
Yeah, log out.
Okay, perfect. See you. Bye.